mentee is Dr. Minnie David K, Consultant, Vitreoretinal Services, Dr. Tony Fernandez Eye Hospital, Alva. And her mentor is Dr. Sheena Liswani, Senior Consultant, Vitreoretinal Services, Dr. Tony Fernandez Eye Hospital, Alva.
Good morning. Case title is Positional Peril Hereditary Reality. A 48-year-old male presented with complaints of flutters and right eye for past 1 week. Patient had consulted another hospital and underwent laser treatment for retinal breaks and was advised to maintain some position. After maintaining position, there was resolution of symptoms. However, he developed field loss more on the nasal side. On examination, his best corrected visual acuity were 6.6 in both eyes, IOP and angle segment were with a normal limit. And this is the fundus photograph brought by the patient prior to laser. There is an elevated retina from 7 to 11 o'clock position with a single horseshoe tear at 10 o'clock position, suggestive of temporal retinal detachment threatening the fovea. Left eye fundus photograph showing inferior to pigmented lattices. B scan showing moderate to high reflective hyperechoic membrane. Then post laser patient came to our hospital presented with right eye temporal RD with a single horseshoe tear, and laser marks were seen to discriminate temporal to fovea. It was connecting aura from 7 to 11 o'clock position, but the SRF was beyond the laser marks and threatening the fovea. It is better demonstrated in OCT. There is a hyperreflective space temporally with the elevation of neurosensory layer from RP, suggesting of temporal RD, but the fovea was intact. Slip in this case, this patient was supposed to maintain right lateral position post laser in order to prevent subretinal fluid tracking towards the fovea. A misunderstanding and wrong position worsened the retinal detachment. Fortunately, patient came on time for consultation. Our plan of management were either going with a scleral buckling or with a pneumoretinopexy. We had a thought of scleral buckling because it was a young patient, macula was on and there was no PVR changes. And pneumoretinopexy because it was a single break within 1 clock hour. In the supratemporal quadrant, no inferior breaks or PVR changes were there. After proper counseling and discussion with the patient, we went with pneumoretinopexy. Cryo was done to the break and 0.3 cc 100% C3 was injected, and patient was advised to maintain strict left lateral positioning. Post-op day 1, patient maintained visual acuity of 6.6 and settled the RD. Post-op 3rd week also patient maintained visual acuity and complete settling of RD. Wrong positioning by the patient worsened the retinal detachment in this case. Timely management with pneumatic retinopexy with correct positioning salvaged retina without resorting to more invasive and expensive retinal surgeries like buckling or vitrectomy.
Good morning. So this is a case of a macula on RD which was treated initially with laser, then we did a pneumatic retinopexy. So coming to reg RDs, the treatment options are many. It can be either a PPV or a buckle or a pneumatic retinopexy in select cases. So pneumatic retinopexy is a minimally invasive non-incisional procedure. It involves 3 simple steps. First is the cryo to the break, second is the injection of the expansile gas, and third is an appropriate position. So, but there are certain indications for pneumatic retinopexy. Not all RDs are amenable to pneumatic retinopexy. The indications are the break should be located in the superior fundus and no break in the inferior retina, and there should be minimal media opacity and no or minimal PVR, and the patient should be able to maintain appropriate position for a period of time after the procedure. So what does the literature say? In the cases which are amenable to pneumatic retinopexy versus scleral buckle, this is a study by the LVPI group, and they compared both procedures. The primary anatomic success rate was a little higher in buckle, but the other parameters that were measured, myopic shift was almost nil in pneumatic retinopexy. As expected, there is a myopic shift in buckle. Visual acuity was almost the same. The procedure time was very significantly shorter in pneumatic retinopexy as versus the buckle, and cost also was less than 50%, including second surgery if the need arose. and the other complications were almost the same in both procedures. What does literature say about rheumatic retinopexy versus PPV? This is a study done by a group in Canada. And again, the primary anatomic success rate was higher in PPV. But as far as all the other parameters that were measured, the visual acuity, the vertical metamorphopsia, and the rate of cataract formation in phakic eyes, and the quality of life, in all these parameters, the rheumatic retinopexy arm score was much better. So rheumatic retinopexy has many advantages. It's an outpatient procedure with less discomfort. There's no change in refractive error, there's no diplopia, fast ocular recovery, and the cost is significantly lower. However, there are disadvantages. Not all detachments are suitable for this kind of procedure, and it requires patient cooperation and positioning. And in case it doesn't settle with a pneumatic retinopexy, one should be able to take over and go on to the second procedure. So what are the learning points that we've learned from this case? Effective communication. One should be able to communicate well to the patient as in the first procedure as also second. Positioning and appropriate positioning is crucial for success or the non-success. And it should be considered in select eyes because it's quicker, lower cost, and fewer associated unwanted outcomes.
I thank Dr. Mini and Dr. Sheena for their presentation. Now over to the judges. Dr. Gopal sir, based on your expertise, would you have tried the same or alternative methodology to approach this case?
Let me just highlight it a little bit. Before I give it to Dr. Gopal, I just wanted to ask you, your learning point here was that you failed, that barrage laser did not succeed. That was the point, that was a pitfall. So shouldn't you have highlighted the learning point based on that?
No, why was because of the positioning.
No, that was one reason, but you should have given a percentage of how many does work, the laser as such, in a barrage laser which has a tear with fluid in it. How much does it, what is the success rate? That way she would have learned. I mean, it's okay you did pneumoretinopexy, you're an expert in that is definitely there. But she is a mentee. She has to learn why it failed in the first place. That is my point of view. And you too.
No, so you say that positioning is very important. But many patients, when they are sleeping, they go through a rapid eye movement sleep, where eye will move completely away. So is positioning that important? That is the point.
Yes, it is. I think it is important because in this case, the positioning was exactly the opposite. So probably it would have maintained if it was done in the first.
And number two is you can see that the laser marks are a little away from the tear.
The fluid was also
so in the presence of already existing retinal detachment which is started, now if you laser barrage around it and it's quite a little posterior, shouldn't you have lasered a little more broader?
So we also were wondering the same. I mean, it was done at another center, so we were also thinking the same, but that was already done and the fluid had already extended beyond the native laser.
Because already existing retinal detachment is superior product, probably the retinal detachment would spread, and I do not know whether position would have made that much of an impact as much as we are talking about. Okay, thank you very much.
I mean, another option is when you give the barrage, along with the barrage, just give transconjunctival choroidopexy to the HST. When it is treating a subclinical RV with a single HST which is little peripheral, you give the barrage and simultaneously give some transconjunctival cryo. Probably it will work. So that's another option.
Please collect your mementos from Augustine.
Next, we have a case of traumatic lens dislocation by the mentee, Dr. Maya TJ. She is a consultant in glaucoma